Good afternoon, ladies and gentlemen. My name is Diana Hitch, and today I'd like to talk to you about primary induction hypothermia. Did you know in the United States that one of the leading causes of death is cardiac arrest, but that's usually due to the secondary injury to the neurological system? Research has suggested that primary induction hypothermia in the post-cardiac arrest patient who has had return of spontaneous circulation is improving neurological outcomes. This is due to the decrease in the cerebral rate of metabolic oxygen consumption, the decrease in free radical production, and the lower release of excitatory amino acids. First, I'd like to talk to you about primary induction hypothermia and how it affects the cerebral rate of metabolic oxygen consumption. As primary hypothermia is induced, the cerebral demands for oxygen and energy are decreased. Long Bayou and Fen Xu of the Department for Emergency Medicine at the First Affiliated Hospital of Soochow University have indicated in their studies the degree to which this is impacted. As you can see here, the cerebral rate of metabolic oxygen consumption and also energy expenditure is decreased with each degree in Celsius that the body temperature is cooled. Long Bayou and Fen Xu indicate that there is approximately a 5% reduction in cerebral rate of metabolic oxygen consumption with each degree of temperature that the body is cooled in Celsius. In 2008, German studies have also indicated that there is a 5.9% decrease in energy expenditure with each degree of Celsius that the body temperature is cooled. Therefore, the cerebral rate of metabolic oxygen consumption and the decrease of the energy expenditure helps prevent the neurological collapse. Another reason that primary induction hypothermia is improving the neurological outcomes is because of the decrease in the free radical production. Free radical production is one of the main causes of reperfusion injury. With primary induction hypothermia, free radicals are reduced. Therefore, it's preserving the stability of the oxidant and antioxidant balance, this is a key factor which serves as a neuroprotectant. One of the final reasons that primary induction hypothermia is increasing the neurological outcomes is that there is a lower release of excitatory amino acids. Excitatory amino acids, mainly glutamine, is released 1 to 5 hours post-injury. Glutamine and other excitatory amino acids are responsible for the inflammatory cascade. With the release of glutamine, this activates certain receptor sites, increasing the permeability of the brain's microvasculature. This enhancement of the microvasculature of the brain leads to the influx of calcium, which therefore creates cerebral edema, increased intracranial pressure, and eventual brainstem herniation. For these three reasons, primary induction hypothermia is one of the recommended standards of care for the post-cardiac arrest patient who has had return of spontaneous circulation. Hypothermia induction has time after time produced better neurological outcomes for these patients who have suffered a cardiac arrest. Thank you. Does anyone have any questions?
Yes. Is it beneficial to induce hypothermia on all patients that experience cardiac arrest?
Thank you. That's a really good question. No, hypothermia, there is certain limitations to what the suggestions are. American Heart Association guidelines indicate that any patient who has experienced an out-of-hospital cardiac arrest due to ventricular fibrillation or other cardiac causes have hypothermia induced. There are also hospital-based measures that exclude a person from having primary induction hypothermia. Some of these include that the presence of a terminal illness prior to cardiac arrest, the pregnancy in the patient who has had cardiac arrest, and other patients who have had coagulopathies or other bleeding disorders prior to this cardiac arrest. I hope that explains everything. Do you have any other questions?
Yes. What is the recommended temperature to cool a patient down to?
American Heart Association guidelines. Thank you. That's a very good question. Guidelines currently suggest that the patient be cooled to 32 to 34 degrees Celsius rapidly, and that once that body temperature is achieved, they be maintained there from 12 to 24 hours. Hypothermia is induced in several different ways in non-invasive and invasive means. Non-invasive means could mean the application of ice packs to the groin, axilla, and neck areas, the use of a cooling blanket under or over top of the patient. Invasive means would be the rapid infusion of iced or chilled saline, and also there is endovascular heat exchange catheters that can be used. If there's no more questions, I thank you for listening to my presentation on primary hypothermia induction.